Thanks for having me here again this year. It's the third year that we've kind of done a little presentation on this. And we're sort of privileged to live in an era when the evidence behind what we're doing at Cedars is developing rapidly, and it's a challenge to keep up with it. When we started our program in 2014, there was really not a lot of evidence in the literature about, in particular in the preoperative space, for what we're doing, and so it's nice to see other centers becoming more interested. So I don't have any disclosures. I direct the preoperative pain program at Cedars. I'm on faculty for internal medicine. I get paid by the hospital. Outline of the talk really quickly. I just want to talk about the rationale for why you might want to reduce opioids. There's really no evidence right now that shows that reducing opioids improves long-term outcome. There's never been a randomized study on it, and the opioid programs themselves, opioid weaning programs, are so new that there's just hasn't been enough time for that to develop. But I'll talk about the evidence that we do have, the implications for current practice, and then some areas we might want to investigate in the future. So the rationale for opioid weaning. Really, there have been two types of evidence put forward in the literature. One has to deal with reduction in postoperative complications, wound infection, hospital readmission, and reoperation within a year being first and foremost among those. And then a second type of evidence that deals with patient-reported outcomes. We heard in our first session of the conference about how patient-reported outcomes may come to be used as a way to determine surgical appropriateness. So it's clearly in every spine surgeon's interest to try to optimize those. And those come in two basic flavors in this literature. One is patient satisfaction. The other is minimal clinically important change in various parameters such as the osseoestry, the SF-12, the neck disability index, etc. So weaning endpoints. This gets back to what Terry just mentioned. They've been largely arbitrary, and I'll talk about the evidence that exists, but you can characterize that in terms of a percentage dose reduction of a patient, an absolute reduction in daily morphine equivalents, and that's how we've tended to run our program over time. And then you can also talk about it in terms of chronicity, and this is a real splitter in the literature right now between the morphine equivalent dose reduction and the chronicity of use and which one's more important. So I'll talk about that. Also unknown are how long one might need to do this before the surgery. Is it a period of months? Is it a period of days? What's effective? And then how short-term versus long-term opioid users may have different preoperative targets. If you assume that chronicity is the most important thing, then a short-term, someone who's only been on a higher dose for a short period of time may not need it quite as aggressive weaning as someone who's been on it for the last 3 or 4 years. So diving into the literature, we've known as long ago as 2014, and even before that, the spine surgery patients in particular don't do well when they are on preoperative opioids chronically. And here this study actually looked at self-reported MEDs and correlated the dose of the opioid with the reduction in the patient-reported outcomes after the surgery. And this was done at a couple of centers. Vanderbilt has a nice spine surgery registry. It'll come up a few times in this talk. Moving forward, and we started our program right about the same time in 2014, and that was kind of the state of the literature at the time. Moving forward to 2016 and 2017, we started to see more discussion in the literature of what was being done, and I've kind of cherry-picked a few of these articles. There's a lot more than I'm presenting and I have time to present today, but essentially here again, statistically significant trend emerged where higher opioid prescription dose was associated with worse self-reported outcomes in spine surgery patients. And then in 2016 was really the first evidence that was reported about a pre-op opioid reduction and the results of that reduction. This was in total knee arthroplasty patients at UCSF. And it was a small trial. It was 140-something patients, and essentially they tracked their patient-reported outcomes, and they said that if they weaned them down more than 50% of their baseline dose, that they would essentially have the same patient-reported outcomes as people who were not on opioids before the surgery. And again, that you can sort of criticize all of these studies on the basis of the fact that the data is self-reported, that the N is small, and so this is all not very high level or strong evidence, but it again is the only evidence that existed, and so this paper gets a lot of credit for the vision there. In 2017, McAnally up in Alaska put together a really nice review of all the evidence and all the rationale supporting preoperative weaning for pre-surgical patients. This was not specific to spine, but I just wanted to draw attention to the fact that he highlighted in this paper, he writes a lot with Beth Darnell out of Stanford about the psychometric and psychological and psychiatric aspects of this. And the key thing here is that these patients are not normal before they get hooked on opioids or before they escalate their doses. A lot of them have underlying psychopathology, and in particular, self-efficacy and resilience are two concepts that come up again and again and again in the literature. So anything we can do in the weaning process to bolster the patient's sense that they can actually change their self-efficacy and resilience is going to help them. And I would argue that the weaning process actually does that. That empowering a patient to help make reductions that they didn't think were possible actually helps them to develop their own sense of self-efficacy. So here we have in 2018. 2018 was a huge year for this literature. Richard Deo, who was instrumental in the CDC 2016 consensus statement on use of opioids in chronic pain, basically saying opioids shouldn't be used for chronic pain, and if you do use them, you better document how it's actually helping the patient and that the patient's better on it than off it, and setting some guidelines for the amount of opioids that people should be on. He published this paper in spine surgery patients, taking a look at how many of the people who are on opioids for a few months before surgery, how many of those people actually get off of opioids afterward. And the answer is about 10%. It's 77% of people stay on the dose that they're on, about 12% increase, and about less than 10% actually ever get off of opioids after their surgery. This was from Oregon. This was using something that'll come to be standard, I think, in the literature, which is looking at the state prescription databases to get the consumption numbers on the patients. So that part of this study was very reliable. It was over 2,000 patients. So I think we really need to be circumspect in what we're promising to spine patients, particularly the ones that are taking opioids before their surgery, and speak specifically before the surgery about what the goals are, and also set targets for them about what their dose needs to be preoperatively, but also more, as importantly, probably what it needs to be postoperatively and by what period in time. And here we can also see that the dose of the opioid actually correlates with the likelihood of being on opioids chronically. So the higher the preoperative dose, the more likely they are to be on the opioid long term. Later in 2018, we had Jane out of Ohio doing this series of papers. This was looking at insurance data, claims data out of the Humana database with 24,000 patients. And essentially there were 3 papers, and it all looked at chronic opioid use and the risk of various actual post-op complications. First one was on cervical fusion, and it basically said 22% of the people they did cervical fusions on had preoperative chronic opioid therapy. Their 90-day wound complications were 40% higher than baseline, and their risk of repeat cervical fusion within a year was 20% higher. And they, in their conclusions basically mention, as do many of these papers, that weaning is probably something we should all be thinking about. The risk may be reduced by restricting the duration of the preoperative opioid use or weaning off before surgery. So this idea of weaning seems to suggest itself over and over again to people studying whether it's patient-reported outcomes or surgical complications. His next paper looked at the lumbar 1 and 2 level posterior lumbar fusions, and this was an interesting paper because it actually attached some cost numbers to the increased incidence of wound infections, of hospital readmissions, and reoperations at the same site. And I don't know if I can point here. Oh yeah. So you can see some dollar values here, and the ones that jump out are the hospital readmissions, the revision fusions, and then the wound infections really jump out. And here are the percentage increases. The preoperative chronic opioid users are 7%, and without it's 6%. And that magnitude of difference, 1 to 2% in this database, kind of stands out. Again, they're not in this particular study looking at the amount of opioid that the person is on. So all these studies have individual weaknesses, and that would be one of them for this study. And then the final one was very interesting because it combined lumbar fusion and major joint replacement, hip and knee, studied them all, same database, and said, okay, how do these people do? And here, the interesting thing was looking at the duration, and this gets at that question of how long do people really need to be off. They looked retrospectively at the data. They studied people who had been on for longer than 6 months, studied people who had been off for the 3 months before surgery, and then they studied people who were on at 6 months and then off for the 3 months, and they looked at their risk of complications, and they found that in many cases, and it varied a little bit, the complication varied a little bit between the hip and knee patients and the lumbar fusion patients, but basically found that if you're on at 6 months and off at 3 months, for some of these complications, for instance, hospital readmission, your risk of readmission would go from 44% higher than baseline to back to baseline. So this was, again, one of the first studies to really look in a hard way at, can we reduce the risk of this population, or are they all just debilitated and going to be readmitted no matter what we do? So I think this is sort of an anecdotal evidence to support the notion of weaning. 7 seconds. Okay, so this was an interesting paper. This is the first one that looked at dose specifically, and they found there was a kinked model. This was from Vanderbilt, 1,300 patients, and the result of this paper, when they linked the state opioid data with their registry, was that there was a threshold. Basically, there was a kink. If you were above 50 MED all the way down to 90 MED, you had a much lower chance of reporting being satisfied with your spine surgery at a year. So this was really the first quantitative study that looked at dose and tried to figure out what is the dose we should be weaning to, and immediately, basically, we started reducing our target from 80 to 50. And in reality, it might be 30 or it might be less. And so the next study was interesting. They had some of the same authors looked at chronicity, and they said actually chronicity and the dose go together. They're sort of surrogates for each other. 73% of the people that were on for more than a few months before surgery had doses, MEDs above, I think, 40, and we'll see in this next slide that that's true. But the conclusion of this study was that the chronicity might arguably actually be more important than the MED, but because they're covariates, it's hard to tell. And so here's kind of a take-home slide. As a spine surgeon, if you're putting people into surgery and they're on chronic opioids, you're going to see that their patient-reported outcomes across all these different measures are going to be less likely to be good. And there's the difference in how the opioid doses vary between the two populations. The chronic people are on much higher doses. And here's the thing showing that basically chronicity makes dose less important. So I'll finish by saying that that's sort of a lot to digest, but practically speaking, what can you do? I'm sure a lot of people are in practices where they don't have a ready go-to source of someone like me that they can refer a patient to specifically work on this issue. And what you need is a good primary care physician or pain management physician who's willing to see these patients, and it takes more time than you'd think, 30 to 40 minutes an appointment usually, to get people on board with this process. So this was basically a case report from Darnell saying, hey, you don't really need the big multidisciplinary team. You can get by with a small number of dedicated professionals. But to conclude, I would say that the surgeon is always going to be a key component of this, and that the surgery represents an opportunity for these patients, and never underestimate the value of explaining the importance of this to the patient before their surgery and using that as an opportunity to make progress. I'll conclude there because I'm over time.